Now, carrying on with our thinking about the National Early Warning Score, we want to think about some things that can cause high and low changes to particular parameters. So why might the respiratory rate increase? Why might it decrease? Why might the temperature increase, or why might it decrease? So things that can cause highs and lows, variations of the parameter that we're considering. And basically there's two reasons this can happen. Sometimes it's physiological, but of course what we're looking for in healthcare is the pathological situation, when this is a clinical feature of something going wrong with our patient. So let's start off with thinking about the first criteria, which is the respiratory rate. So we should count the respiratory rate for a full minute. What I normally do, actually, because it's best if the patient doesn't know you're counting their respirations or their ventilations, I normally just ask them to close their eyes and think of something nice for a minute, and then I can watch the movements of their chest and abdomen when they don't know they're being observed, and then usually tell them afterwards what I was doing. But different people have different ways of doing it. So, as with most of the parameters, they can be increase in respiratory rate into abnormal situations, or decrease into respiratory rate down into abnormal situations. And these are two useful terms. Tachypnea means fast breathing, bradypnea means slow. Now if you're in the States you don't put the O in, the spelling's the same otherwise, but in the UK we put in the O. Tachy, T-A-C-H-Y, always means fast. Brady, B-R-A-D-Y, always means slow. And pnea means to do with air. It's where we get the word pneumatic tyre from. It's full of air. So fast breathing, slow breathing. And as we've said, this can be physiological. Now, increase in respiratory rate will be caused by stimulation of the sympathetic nervous system. And a reduction in breathing rate will be caused by stimulation with the parasympathetic nervous system. And you'll probably remember that these are both branches of the autonomic nervous system. So the autonomic nervous system, that which is not under the control of the will, that which works automatically, divided into the sympathetic and the parasympathetic. And it's the same with heart rate. Increase in heart rate will be sympathetic, decrease in heart rate will be parasympathetic. As with blood pressure, increase in blood pressure will be sympathetic, decrease will be parasympathetic. So these increase in heart rate can be normal, of course, because it can be caused in emergencies, excitement, exercise, because of increased sympathetic activity. But increased respiratory rate, the tachypnea, can also be a clinical feature, alerting us to altered physiology. So, for example, if the respiratory rate increases, that can be the first sign, actually, of a developing infection, because the patient breathes more quickly to get more oxygen into the body. That allows the body's metabolic rate to increase. When the metabolic rate increases, that increases body temperature in infection. When we increase the body temperature, that is good, because the immune system works best at febrile pyrexial temperatures. So very often, increase in respiratory rate can be the first sign that something's going wrong. So consider sepsis or infection, but then there can be increased respiratory rate, classically, for example, in diabetic ketoacidosis, DKA. In this situation, when the body doesn't get enough insulin, it makes ketones, and the ketones are acidic, and that will be detected by the respiratory centre in the brain stem, in the medulla oblongata of the brain stem, and that will increase respiratory rate, as indeed will any form of acidosis. And of course, all the lung conditions can lead to tachypnea. Asthma, pulmonary embolism, pleural effusion can cause it, where there is an effusion of fluid between the visceral and parietal pleural membrane, or pneumothorax, spontaneous or traumatic, where there is air in between the visceral and parietal pleural membranes causing partial collapse of the lung. Emphysema, one of the forms of COPD, is often associated with a faster heart rate, and it can occur in panic attacks as well. So we can see that there's a few pathological causes there of tachycardia. Now, as we've said, not tachycardia, tachypnea, increased breathing rate. Now, as we've said, bradypnea can be caused by parasympathetic stimulation, so it's associated with rest, relaxation. It will help the digestive processes. But there's various medical conditions where we can see slower breathing as well. For example, hypothyroidism causes a generalized reduction of the metabolic rate. Or sometimes we can see it if there's increased intracranial pressure, increased pressure within the patient's cranial cavity. And drugs can slow down respiratory rate, excessive amounts of alcohol, for example. And the one that's absolutely classic for slowing down respiratory rates, indeed to the point where it can be fatal, is opiates, morphine, heroin, diamorphine, these sort of drugs. And muscle relaxants can do it as well in the anaesthetic sort of situation. So if we're worried about the patient's respiratory rate being low, we should always go on and check the oxygen saturations. And that's the next parameter we look at. And above 97 is considered normal. Now the oxygen saturations are it's the percentage of the hemoglobin in the blood which is oxygenated. So each hemoglobin molecule in the red cells can carry 4 molecules of oxygen. And it's how saturated these are. So if the patient has 100% saturations, as we do see, then what that means is that all of the hemoglobin molecules in the patient's blood are carrying 4 oxygen molecules each. And if the patient's saturations are 98%, then it means only 98% of the hemoglobin molecules in the patient's blood are carrying oxygen molecules. So it's amazing to think that the lungs are often working with 100% efficiency, or certainly in the normal situation, as we see, above 96% saturations. Now, hypoxemia, the emia part, again in the States you don't put the A, but hypoxemia is low levels of oxygen in the blood. Hypoxia is low levels of oxygen in the patient's body tissues, but hypoxemia is specific to the blood. And these are all the different causes of hypoxia that we can think about and have thought about on talks on hypoxia, which are available on this channel in great detail if you want to watch them. So we can think about extrinsic hypoxia, where there's not enough oxygen in the air, pulmonary hypoxia, where the lungs aren't working properly either because they're not being ventilated, or the lung tissue is diseased, or the oxygen is not diffusing from the alveoli into the blood. There can also be anemic hypoxia, where the blood is not transporting the oxygen, or stagnant hypoxia, where the blood and the tissue fluids are not circulating around the body. And there can also be a histotic hypoxia, although in histotic hypoxias the oxygen saturations will probably be normal. Now, the one that can catch people out on the oxygen saturations, let me just write this down, it's carboxy. Carboxyhemoglobin is the one that can catch people out. Now, what carboxyhemoglobin is, it's a combination of the hemoglobin and well, first of all, hemoglobin plus oxygen gives us oxyhemoglobin. Which of course is completely normal. But the hemoglobin, if it combines with carbon monoxide, CO, carbon monoxide, that gives us this carboxyhemoglobin. Now, the thing about carboxyhemoglobin is that the current generation of oxygen saturation probes that we're using while they can differentiate between oxyhemoglobin and deoxyhemoglobin to give us an oxygen percentage, they cannot differentiate between oxyhemoglobin and carboxyhemoglobin. So actually the oxygen saturation figure that you get on your oxygen saturation probe is actually the combination of the oxyhemoglobin and the carboxyhemoglobin together. Now normally that's not a problem, but if the patient's been smoking, or especially if they've been in a fire and the carboxyhemoglobin levels are high, that means that the oxygen saturations could actually be well within the normal range, could even be 100%, and yet the patient could be hypoxic, because when the hemoglobin molecules are associated with the carbon monoxide, they are unable to carry the oxygen as normal. So when they're carrying the carbon monoxide, that sticks to the hemoglobin, and the patient won't be carrying the oxygen, but that won't register on the probe. But apart from that, these oxygen saturation probes are absolutely brilliant and remarkably useful. Now moving on down to the next criteria, we're looking at temperature. Now the temperature's high, that can be a hyperthermia, pyrexia, fever, febrile. Now hyperthermia means that the patient's temperature is high, usually for environmental reasons, and the set point in the hypothalamus is at the normal level. It's just that the body temperature is above it, and in that situation the body will try to bring the temperature down. Now pyrexia means that the temperature is high because the set point in the hypothalamus has been raised. Now pyrexia means an increased body temperature, fever means the same, and febrile means the same. So these three words actually all mean much the same to me. I don't know if some linguist would want to argue with me about that, but a febrile patient has a fever and they are pyrexial. It means much the same thing. Now the reason for this usually is caused by infection, because the infection will be detected by the white cells, and the white cells will release the pyrogens, and the pyrogens will go to the hypothalamus, and the hypothalamus will increase the set point and increase the body temperature. And the reason for this is the immune system works best at pyrexial temperatures. So in most situations the immune system is working best between 38 degrees centigrade and 40 degrees centigrade, or even more. So remember, the immune system's working better at pyrexial temperatures than it is at normal temperatures. The body has done this quite deliberately via this pyrogen hypothalamic mechanism. Special chemical transmitters in the hypothalamus, cyclooxygenase, facilitate this. But the hyperthermia would be environmental reasons. So for example, if it's hot weather, working hard. Now particularly if the sweat can't dry, if people are dressed, for example soldiers in full combats, if the sweat can't dry they can become hyperthermic, and tragically there's been deaths from time to time of people training for the military, working very hard in hot weather and wearing combat so that their sweat can't dry. Dehydration could also be a cause of this. If you can't sweat, then you're at risk of hyperthermia. But in that situation, there's no change in the hypothalamus. Whereas when the white cells release the pyrogen, the cyclooxygenase changes in the hypothalamus. That's usually infection, causing pyrexia, the patient's febrile. So that could be caused by bacterial infection, viral infection, but it can also be caused by tissue damage, surgery and trauma. So if the patient's unwell and febrile, one of the problems is just from the temperature, we can't tell whether it's a viral or bacterial infection. So that's hyperthermia when the temperature's too high. The converse of that is hypothermia when we're into the hypothermic ranges. So low body temperature might be 35 to 36. We would normally describe hypothermia as less than 35 degrees centigrade. Now hypothermia is usually environmental, it's a cold environment, but also if the patient's wet, because then they get a wind chill factor. So people out on the fells who are wet and in windy conditions can become hypothermic. And old patients who have what we call a long lie, so sometimes patients will fall and injure themselves in the evening and not be discovered till the morning, and they can be hypothermic. Hypothyroidism, again, is a possibility for hypothermia. And there is something called a cold sepsis, where the body temperature can be normal or low, but the patient still be septic. Now, basically, if someone's cold and they're shivering, I'm not too worried about it because they're able to shiver and bring their body temperature back up. We can just help them to do that. But if someone's hypothermic and not shivering, if the hypothalamus is not trying to bring the body temperature back up, that would concern me greatly. So a hypothermic patient who is not shivering is a medical emergency. Alcohol is another common cause of hypothermia, especially in cold environments. It's a common cause of death in cold countries where people might drink vodka and then walk home when it's minus 10 or 20 outside and simply not make it. But even in this country, even in England, in more temperate climates, we get people who have been drinking who tragically die of hypothermia after the alcohol, the combination of the alcohol and the cold, and tragically it's often young people that are affected. Moving on to the next criteria is blood pressure. Now, a low blood pressure would be hypotension and a high blood pressure would be hypertension. So again, hypo low, hyper high. Hypo rhymes with low. Tension, the pressure. And when we're talking about hypo and hypertension, in this context, we're always talking about the blood pressure within the systemic arterial system. So hypertension is caused by sympathetic activity. So again, we would expect that in the emergencies, in the excitement, the exercise. But if someone's blood pressure is high, that can be what we call primary idiopathic, where the blood pressure just goes up. And it can be worse if there's a high salt diet, especially in people in Afro-Caribbean, with Afro-Caribbean genetics, because race and genetics are factors in hypertension, typically black races having more problems with hypertension than white races. Obesity is a risk factor, lack of exercise is a risk factor. Chronic alcohol use can lead to hypertension, and increasing age as well. But there's also what we call secondary hypertension, where the blood pressure is high because of renal disease, such as glomerulonephritis or arterial disease, or because the patient's taking drugs such as adrenaline, dopamine, or steroids, can all raise blood pressure, causing hypertension. So we can see hypertension, but again, we notice that doesn't trigger with the news until we're really, really very high. And to tell you the truth, I would be worried about blood pressure well below that level, although it doesn't trigger on the news until it gets to that very, very high level. Now, hypotension, if the blood pressure is too low, and we're going into these categories here, well, hypotension is a parasympathetic activity, so again, it's normal with rest and relaxation that the blood pressure goes down. But we can get a pathological drop in blood pressure after anything that can affect the heart, really. Myocardial infarction, myocarditis, valve failure in the heart where the heart can't pump properly. Cyanide is a toxin which affects the heart muscle and reduces or can completely take away the ability of the myocardium to contract. Chronic heart failure can lead to hypotension when the body is unable to generate an adequate cardiac output, often caused by long-term coronary arterial disease. Another one we see quite commonly is the vasovagal episode, where people just faint and normally come round when we lie them with their head down and their feet up. But this can also be a problem in the post-surgery or traumatic situation, so hypovolemia. Hypovolemia is low blood volume. Hypovolemia can be caused by hemorrhage, dehydration, burns, and very often in this situation we get a fast pulse, weak thready pulse combined with the low blood pressure. Reduced peripheral pulses might also be present. And if the blood pressure is very low, then this becomes shock. The patient becomes shocked. And again, we've done talks on shock. Shock could be hypovolemic, could be cardiogenic, could be allergic, anaphylactic type, could be a septic shock, a neurogenic shock, or an obstructive cause of the shock. And again, we've done talks on those in more detail. And the blood pressure should be seen in context of the heart rate, as indeed the heart rate should be seen in context of the blood pressure. Indeed, all observations should be seen in context of all the other observations, really. But thinking particularly about heart rate, tachycardia, fast heart rate, bradycardia, low heart rate. So tachy fast, brady slow again. So again, tachycardia is a sympathetic activity. So that would be normal in emergencies, excitement, exercise. Bradycardia is a parasympathetic activity. So again, that would be normal in rest, relaxation. It aids the digestive processes. But when will we see tachycardia in the pathological situation? Well, it could be disease of the heart valves. There could be disease of the myocardium, myocarditis. There could be conduction disorders within the heart. There can be a sinus tachycardia where the tachycardia originates above the level of the atrioventricular node in the atria, or there can be a ventricular tachycardia where the ectopic focus is in the ventricles. There could be atrial fibrillation. Many different heart rhythms that can present, that can cause a tachycardia. Could be hypovolemia, hemorrhage, dehydration, burns, as we've said. Drugs such as adrenaline, salbutamol, amphetamines, all of these things can increase the heart rate. And bradycardia, what can cause the heart rate to slow down going into these parameters? Well, parasympathetic vagal activity is normal. The vagus nerve, it's the 10th cranial nerve. 10th cranial nerve. 10th cranial nerve. That's the main parasympathetic nerve in the body, actually. So thinking about causes of bradycardia, other than the physiological parasympathetic stimulation, there can be vasovagal attacks, as we mentioned when we talked about hypotension. There could be heart block affecting the heart, some sort of atrioventricular block, different heart blocks, conduction problems in the heart, hypothyroidism, hypothermia. A common reason why we see low heart rates actually is when the patients are admitted and they're on beta blockers, and we see a much lower heart rate than we would expect. Now, going on to the last criteria of the news, the level of consciousness, where we notice that alert doesn't score, but if the patient's only responding to voice, so if we have to say, "Mr. Smith, are you all right?" only then are they responding. That means they're responding to voice. If they're only responding when we inflict a painful stimuli on them, that's the response at the level of P, and if they're unresponsive, that's U. So V, P or U would all score a 3 on the news criteria. So anything that lowers the level of consciousness, and again there's a long list of things that can lower level of consciousness. Now, blood sugar does not count towards the numbers, so it doesn't count towards the numbers, but it's still a good thing to take from time to time. So there we've looked at respiratory rate, oxygen saturations, temperature, blood pressure, heart rate, and level of alertness as the news criteria, thinking about what could possibly cause higher and lower levels than we would normally expect to see. Just before we finish, urine output should be 0.5 mils per kilogram per hour in adults, although more in children. And again, as we mentioned, we should always check if the patient's in pain and escalate and sign appropriately.